Good afternoon. My name is Tasha, and I'll be your conference operator today. At this time, I would like to welcome everyone to the National LAN event. All lines have been placed on mute to prevent any background noise. After the speaker's remarks, there will be a question-and-answer session. At that time, in order to ask a question, you can press *1 on your telephone keypad. To withdraw your question, press the # key. Thank you. And now I'd like to turn the call over to your host, Ms. Kaylee Doyle. Please go ahead.
Thank you. Good afternoon, everyone. Thanks for joining us for the National Learning and Action Network, or LAN event. We're happy to have you on today as we discuss the important topic of integrating alcohol and depression screenings into whole person care. My name is Kaylee Doyle. I'm a program manager with Television and the Quality Innovation Network National Coordinating Center, or the QIN-NCC. So a few reminders and housekeeping items before we get started today. We want to thank you for joining us in the WebEx Event Center. You will need to access your registration confirmation email and your unique registration ID in order to log into the WebEx. My colleague, Lacey McFall, will be monitoring our chat board today, so please be sure to participate as we go along and feel free to ask questions in chat. The slides, resources, and the recording from today's session will be posted on the QIOprogram.org website under the News and Events tab. So let's start by reviewing the agenda. First, I'll go over our continuing education details. Then I'll introduce you to each of our speakers today. Alan Watts is a patient champion who will be sharing his story. Dr. Rachel Hovis with the Cherokee Health Systems, and Dr. Melissa Clark with the Medical Home Development Group. Following our speaker presentations, we'll have a panel discussion facilitated by my colleague, Dr. Edwin Boudreau, and there'll be an opportunity to address your questions via the phone lines and in chat. If we don't get to your questions right away, know that we're compiling those and we'll attempt to get to all questions during our discussion portion of today's call. And then finally, I'll wrap up with a reminder to complete our post-event assessment and a plug for our upcoming calls. So I want to take a minute to remind all of our participants about the purpose of these important national learning and sharing events. Without reading everything on this slide, I'll just mention a few of the high points. The audience for these events is broad and includes a variety of healthcare provider types, partners, and patients. The purpose of these webinars is to offer virtual learning and sharing events with a focus on ideas and concepts related to healthcare quality improvement. We ask that all participants think of actionable ways to implement the ideas and concepts presented today and make a commitment to share the information with your teams and organizations. And finally, we're always open to new ideas and suggestions for topics, so please feel free to send your ideas in chat or through the post-event assessment. And now I want to address the direct purpose of today's event. Depression and alcohol use disorder are two of the most common behavioral health conditions in the Medicare population, and nevertheless, they are frequently underidentified and undertreated. In honor of May being Mental Health Awareness Month, we selected today's topic to discuss the importance of identifying and treating depression and alcohol use disorder as a critical component to whole person care. The purpose of the session is to give participants effective strategies to integrate alcohol and depression screenings into practice. We're hoping to make this an interactive session. This can be challenging given the large audience, so we ask for you to commit as individuals to being attentive, active, and actionable, and think about all the ways the content is relevant to your work and your priorities. We welcome your active participation by clicking the green checkbox in the WebEx application. And to do this, you can click on the megaphone icon and choose Yes in the drop-down menu, or you can also type Yes in chat. So hopefully all of you are committing to being attentive and active by putting Yes in chat or putting green checkboxes. We're excited to be offering continuing education credits to all attendees for participating in the session today. We offer credits to all physicians, physician assistants, registered nurses, nurse practitioners, dietitians, pharmacists, and pharmacy technicians. We also offer certificates of attendance. If you have requests for additional accreditation types, we welcome those, again through the chat or in the post-event assessment. In order to apply for the continuing education credit, you need to do the following things. Attend this entire event, complete the post-event assessment upon exiting the WebEx session at the end of the event, and then once you have completed the post-event session, you'll be led to the CE evaluation website, and you have to complete that evaluation as well. For any technical assistance related to the CE process, please email Nikki Rossellis, and her email will be posted in chat. So this slide is a disclaimer from our partnering provider, CRW Associates. This activity awards 1.5 AMA credit hours for physicians and physician assistants, and you can reference the slide for the full CE statement. This activity also awards 1.5 contact hours for nurses and 1.5 continuing professional education units for dietitians, and this slide also references the statements for those entities. And then another disclaimer, we want to report that the planners and faculty for this event, CRW and Associates and Teleton, do not have any financial relationships to disclose, nor was any commercial support received for this activity. Finally, here are the disclosures of financial relationships. Again, just a reminder, you have to participate in the entire live activity to claim the continuing education credit, and the link to the online evaluation will be provided after you complete the post-event assessment. Okay, so before we begin with our speaker presentations, we wanted to get an idea of what types of organizations are represented on the call today. So we'll be opening a poll. If you can please complete the poll of which organization you are with. We'll give a few more seconds for everyone to complete that. Okay, and then while those results are being compiled, I'll review the session's objectives for today. So by the end of the call, you'll be able to recognize behavioral health as a factor in healthcare inequity and poor health outcomes in urban medically underserved populations. You'll be able to describe how to incorporate behavioral health and substance misuse screenings into the practice workflow. You'll utilize two strategies for initiating a conversation with patients about screening results, enhancing patient engagement, and motivating health behavior change. And lastly, you'll be able to identify effective community partnerships in achieving whole person care. So I'm looking at the poll results. Looks like the majority are ClinQIOs or we're not able to answer, so go ahead and chat if you weren't able to complete the poll, what organization you're with today. Okay. At this time, I want to introduce our first speaker, Alan Watts. Alan is a patient champion and a voice for patient and family-centered care, and he'll be sharing his story with us today. Thanks for being here, Alan. The floor is yours.
Thank you very much, and good afternoon. Thank you for allowing me to share my story. My wife, Debbie, was diagnosed as bipolar after the birth of our daughter. Although Debbie was very smart academically, she didn't take good care of her health. She was a heavy smoker, overweight, and diabetic, and she had recurrent urinary tract infections because of her diabetes, and acted as if taking her insulin was optional instead of a daily requirement. We both worked at Augusta University Medical Center, and I became a patient advisor around 2006 to be an advocate for Debbie. The patient advisory councils at AU Medical provided input for the design of a sequestered behavioral health unit that was located within their emergency department at the hospital. And my experience as a patient advisor there helped me cope better when Debbie passed away during the Thanksgiving holidays in 2012. I've been able to share my story at speaking events associated with Augusta University Medical and have been on working groups with PFCC partners in Long Beach as well. I'm particularly glad to be part of today's presentations because I believe that alcohol and depression screenings are helpful in a primary care setting. My primary care provider is the Family Medical Center at Augusta University Medical, and they are a top-tier patient-centered medical home in family medicine there. While my primary care physician was very understanding and helpful when my wife passed away, I felt overwhelmed with everything I faced. I didn't really know that I was depressed. I just felt overwhelmed. And if we had discussed more about how I felt overwhelmed, and if I was able to complete all of the things about Debbie's passing away that I should have completed, it would have been more helpful to me. I look forward to learning more about depression and alcohol screenings and whole person care settings, and thank you again for allowing me to share my story. And
Thank you, Alan, so much for being with us today. And now it's my pleasure to introduce Dr. Rachel Hovis, who's an internal medicine physician with the Cherokee Health Systems, which is a federally qualified health center in Knoxville, Tennessee. Dr. Hovis will discuss strategies to achieve behaviorally enhanced primary care. Dr. Hovis, we appreciate you being on today, and the floor is yours.
Thank you. I'm glad to be here. Thank you for having me. So, I'm trying to advance the slide here.
Yeah, just 1 minute.
Okay. Thank you. So while we're working on that, first, I just want everybody to stop and think about how common depression and substance misuse is. You know, it's funny when you hear primary care providers talk about, well, I don't treat depression, I don't treat mental health disorders, I don't treat substance misuse, and that's just simply not true. Because of how common it is, we all treat it, we just aren't doing a very good job of it, or we're just simply not identifying it in our practice. It's just so common that we're all seeing it, we just may not be identifying it, we may not be intervening, and we may not be getting these patients the help that they need. So, can I advance the slide?
Yeah, you should be able to now at the arrow at the top of the slide.
Okay, let's see. There we go. Okay, great. Thank you. So this slide just shows how common it is. 19 million adults, data is from 2016, had substance use disorder. 10 million had a serious mental illness, and the overlap there is astounding as well. 2.6 million adults had both. So this, again, we all see this. We just may not be identifying it. We may not be intervening, and we may not be doing right by these patients. This is a distribution of patients with some type of behavioral disorder. So you can see here that most of it is completely untreated. 57% is not treated at all. 33% is, in fact, treated in primary care, and only 10% goes to specialty care, which would mostly be psychiatry. So 57% is not being even identified or treated. Maybe some of it's being identified and referred, but is not actually making it to treatment. But 33% is being treated, but there's a large amount that we're not identifying and treating. So SBIRT, many of you may have heard of this. SBIRT stands for Screening, Brief Intervention, and Referral to Treatment. You know, here in the U.S., we don't have a healthcare system. We have a sick care system. We often wait until things are so bad that we have to spend thousands and thousands of dollars to intervene. SBIRT really is about wellness promotion. We're really trying to identify people who are at risk early and shift the trajectory for them. Who can we intervene for and shift the trajectory for their lives? So we're trying to identify these people who are at high risk. So we incorporate this systematic screening. We identify those who are at this right side of this arrow here, high risk, and those who are actually using substances, and try to intervene at that point in a spectrum. So as far as screening recommendations go, if you look at the U.S. Preventive Task Force, alcohol screening is the third highest recommendation, only behind vaccines and smoking cessation counseling. And the reason it's number 3 is because of the broad impact that alcohol consumption has on overall health. So the screening followed by a brief counseling intervention was the third highest priority among all preventive recommendations by the U.S. Preventive Task Force. So we have to stop and ask ourselves, are we doing this? Is this a number 3 type priority in our practices? And we've got to think about our workflow. The only way to really work the screening into our workflow for depression and substance misuse is to embed it into our workflow. We've got to embed it so that it improves acceptance. We want all of our staff to accept it. We want our patients to accept it as just a routine part of care. We want it to be sustainable. We want it to last, just as our medical vitals last and stand the test of time. We want screening to last. We want it to be routine, and we need it to be brief. We like to call our screening the behavioral health vitals. We all know what the medical vitals are. They're done every single time by a nurse or a medical assistant who's rooming the patient, and so we want them to tack on the behavioral health vitals as well. And what we use here at Cherokee are the briefest possible screens. For depression, we use the PHQ-2, which is simply 2 questions. Do you have little interest or pleasure in doing things? Is the first question. The second question is, do you feel down, depressed, or hopeless? And if that's positive, then we give them a longer screening questionnaire, the PHQ-9, that goes into a little more detail. And so when the provider goes in, they know already that their screen was positive and they've got some detail going in. For substance use, we use the NIDA quick screen, and that just asks, in the past year, how often have you used alcohol, other substances, prescribed substances other than their prescribed uses. And so we're really just the briefest screen possible, really trying to measure for distress. Which of our patients are at this high risk state and who is in distress? So we have a few pictures just to sort of give you an idea, let you picture in your head of what this is like. We bring the patient in. Here's our nurse checking the patient in, doing the medical vitals like they always do, blood pressure, pulse, temperature, etc. And immediately, right then and there, they do our behavioral health vitals. And this is the quick 2-question PHQ-2 and the quick question NIDA quick screen for substance use. And they do this in a very matter-of-fact way. These are personal questions, but the way we approach them is to do it in a very matter-of-fact way so that the patients feel more at ease and comfortable knowing that this is just a routine part of care. And then the physician, of course, responds to the screen. And again, we want this to be compassionate and matter-of-fact. If we're uncomfortable responding to the screen, then the patient will be uncomfortable. It's just like the way we talk about erectile dysfunction or prostate exams or pelvic exams. If we're uncomfortable, the patient will be uncomfortable. But if we're matter-of-fact, professional, and compassionate, then they'll understand that this is a routine part of care and that behavioral health is just as important as other medical issues are. So we respond in a matter-of-fact, compassionate way. Often we'll ask permission to discuss their screening results and begin by asking, what are your concerns about your depression or this substance use? Tell me how you feel about this, and get the patient to talk about it and go from there. So I wanted just to go through a couple of patient cases just to kind of put this into more real life of what we do every day. So I've got two. Mr. Myers was here for a same-day sick appointment. He was just feeling awful, nausea, vomiting, flu-like symptoms. Young guy, 26 years old, hasn't been to the clinic in a long time. He's on disability, had a car accident 18 months ago. His vitals were pretty stable when he checked in, but his behavioral health vitals showed a negative PHQ-2, but his quick screen for the NIDA for substance abuse was positive. And I haven't mentioned yet that if the NIDA is positive, we give the CAGE aid, which is, the CAGE is a very familiar alcohol screen, but the aid part adds on other substances. So that was positive as well. So the way I would probably approach this patient when I'm interviewing him, I might say something like, your screening results indicate that alcohol consumption is causing problems in your life. Are you concerned about your drinking? And then how he responded to that, I would use that response to gauge his motivation. If he's not motivated at all, we may not be able to go much further, but depending on his response. And I may ask further questions like, if you were to cut back, what benefits would there be? On a scale of 1 to 10, how motivated are you to cut back on your alcohol use? And these are just some motivational tools to see where the patient is, how motivated they are. Because if the patient's not motivated, then there's no point in making a referral or because they're probably not going to go. So you really have to gauge where they are. And you really want to, if the patient's resistant, you want to roll with that resistance. You don't want to argue. You want to just consider the options with the patient and just start the conversation. And remember that this may be a longitudinal process. The next patient, Ms. Green, she came in for an ER follow-up. She had had an injury in a physical altercation, 44 years old. She had been a patient for a long time in primary care, had multiple chronic conditions. Her medical vitals were pretty stable, but her behavioral vitals had a positive PHQ-2, positive PHQ-9, positive NIDA quick screen, and a KJ. So with this patient, I would approach her by asking about the physical altercation. What happened, ask her about her aggressive behavior, if she's concerned about it. And then I might try to link her irritability. A lot of patients don't understand that irritability can be a symptom of depression and substance use, so I may try to link those for her. And linking those two might increase her motivation for treatment because she's had a negative consequence of the depression and substance use. So, I'd gauge her motivation based on that. And we'll often find that, at one point in the patient's life, they may not be motivated, but as we continue this longitudinal relationship, after a hospitalization or an altercation or jail time or other consequences, we'll find that the motivation increases. And if we can catch them in that moment, then and make the proper referral, we may be able to intervene at just the right time. Patients often seek care during distress. And if we can screen for that distress, then we're going to be able to catch a lot of what's going on. We all know that these behavioral health concerns affect all of care, and so we want to be screening for those to have an impact. So primary care is sort of the de facto mental health system. In the U.S., 80% of adults, 93% of African American children have at least one annual primary care visit, and only 6% receive care in the specialty sector annually. So the patients are here. They're in primary care. We're taking care of them already. So anything we can do to address these very, very common behavioral health concerns, we want to do. Primary care providers are having a hard time accessing specialty care for 2/3 of their patients, so we have a hard time getting them there, and that can be a barrier to care. We know that 20% of patients who receive a referral comply, so we need to know that going in, that when we do screen, have a brief intervention, and sometimes refer, that those patients may bounce back and they may not go, and we need to know that going in and accept that as a part of the process, and that's normal, and it may be part of that patient's long-term story that they're going to bounce back, not go in the beginning. Maybe further down the line, their motivation will increase, but that's okay. Primary care can be their landing place. And we also know that patients are most likely to seek care when they're in crisis, and when the distress decreases, they're less likely to engage. So we want to be ready when they are in distress, and by screening, we have that sensitivity for their distress where we're going to catch it when they're there. So intervention in primary care sort of looks like this. We've got primary prevention, and then brief intervention in primary care, and then the smallest part of the triangle should be referral, co-management, and reabsorption. So we can do a lot in primary care. We can intervene, and then for a small number of patients, we can refer when needed. And sometimes we can co-manage with specialty care, and when patients are stable, we can reabsorb. Just like every diabetic doesn't need to go to endocrinology, every depression case doesn't need to go to psychiatry. We can treat that in primary care, or we can reabsorb those patients after they're stabilized in specialty care. So, okay, we'll be happy to take your questions at the end when we have our Q&A time. Thank you very much.
Thank you, Dr. Hovis. Great presentation. And now I'll turn it over to Dr. Melissa Clark. And we'll advance the slides in just a minute. And Dr. Clark is the Vice President of Population Health and Provider Contracting at the Medical Home Development Group. And Dr. Clark is going to be discussing the impact of behavioral health screening on whole person care.
Good afternoon.
I'll turn it to you, Dr. Clark.
Sorry, I was trying to move it, but
is it one other option you can do, Dr. Hovis, is right-click on Dr. Clark's name and click Make Presenter if you aren't able to drag the ball.
I don't see her name.
You may have to scroll.
Okay, there it is.
There we go.
It's on her now.
Great, thank you. Dr. Clark, the floor is yours.
Great. Well, thank you for the introduction, and also I wanted to just thank Mr. Watts for sharing his story. I think it underscores a lot of the principles that both Dr. Hovis and I are speaking of. And I'm going to be adding, I think, the dimension of the practice that I work at, which is called Medical Home Development Group, and talking more about sort of behavioral health as a factor in poor health outcomes and the importance of recognizing it. And in our practice setting, we are in an urban medically underserved community. And also, for those practices that are trying to provide whole person care, we know that there are challenges to be able to being a sort of a one-stop shop and having everything under one roof. So I'm also, in addition to talking about the practice workflow, going to talk about how community partnerships can increase the options for providing additional services for your patients, and how to structure those partnerships well. So Medical Home Development Group is a multidisciplinary practice with several locations in Washington, D.C., and for those of you who might not be familiar with D.C., it's divided into 4 quadrants. Those that are in the north and western parts of the city, the further you go, are sort of more affluent populations. Every kind of provider you can think of to find, you'll find them there in high concentrations. And then in the southern and more eastern parts of the city are higher pockets of poverty and many fewer providers in those areas. We have located in each quadrant of the city, but with propensity in the southeastern and northeastern parts of the city, in order to provide both pediatric and adult primary care and specialty care, And we are the largest provider of office-based opioid treatment in the city. So we have several providers who are waivered to provide office-based buprenorphine therapy to individuals with opioid use disorder. And one of the cornerstones of our practice is the recognition that only about 20% of what we do, and that blue wedge should say 20%. Only 20% of what happens in the doctor's office actually influences disease and thus the cost of care. The rest of the 80% actually fall outside what we do in the clinical environment. And those include things like environment, safe drinking water and clean air, health behaviors, which are also partially dictated by environment. So if someone lives in a food desert, for example, it's going to be more difficult to access healthy food. And then social determinants of health. Those factors such as poverty, employment, literacy, stigma or discrimination or racism, transportation or availability of child care, those things that impact someone's ability to be able to access care and make choices to stay healthy. And in our new environment in which we're undergoing healthcare transformation, provider organizations are now accountable to third-party payers and to their patients for the care that they're providing and for achieving positive health outcomes. So with population health, doctors now have to think about their panel of patients differently and really try to identify those factors from that 80% of factors that fall outside the clinical arena, those that actually impact their care, recognizing them and addressing them, understanding how they impact that person's chronic disease or diseases, engaging those individuals in care effectively, and helping to navigate the healthcare landscape and thereby overcoming some of the barriers to care from social determinants of health. And this slide really illustrates what happens when you are not effectively caring for or identifying and then addressing mental health and substance use disorder in your panel of patients. So these show that if you have a chronic disease like diabetes or asthma or COPD, and you don't have any other comorbidities, your relative risk of hospital admission is low. But as you add in other comorbidities, specifically mental health or substance abuse, that increases the risk of hospitalization threefold. And together, they increase that risk by almost 13 times. And that's true regardless of the chronic disease that you speak of. And then I think we've seen the significant role that behavioral health, therefore, can play in successful disease management. And as clinicians, we have to recognize the interplay of social conditions and life experiences on behavioral health. And in an urban environment, or when you're working with individuals who are from poverty backgrounds or living in poverty, it's important to understand how ongoing traumas or traumas experienced in childhood can actually affect behavioral health outcomes. And these adverse childhood experiences in this pair of ACEs model, which is actually by colleagues at George Washington University, really help to understand sort of the context of the fact that adverse childhood experiences can occur in any environment, whether they be divorce, mental illness in the family, emotional abuse, domestic violence. They can occur in any socioeconomic status. But when coupled with adverse community environments, it can be more difficult to treat, more pervasive, and very important to identify proactively. And another factor is how behavioral health can actually, or traumatic experiences specifically, whether they be psychological or physical, can actually have intergenerational effects. So these are two studies, one published in 2008, the other in 2016, that showed that survivors, number one, of the Dutch potato famine, and then also individuals of the Holocaust, who either were pregnant during the event or after the event, their offspring had genetic changes that mirrored the genetic changes that they had and was correlated with higher rates of physical disease that we think of as health disparities diseases in our society, obesity, diabetes, heart disease, hypertension, but also with PTSD. And so it's important to not just understand the heritability of these issues, but also to recognize, along with the ongoing DNA damage that happens, that building resilience in a population and coping strategies can actually help to decrease the amount of DNA damage and cellular damage that's happening. So there was one study of African American men who reported interpersonal experiences of racism. And they were able to also look at their DNA, specifically their telomeres, to look at DNA damage. And they were able to show that those individuals who did not internalize it and have it affect their self-image or their self-confidence actually did not show the same damage to the telomeres as individuals who did internalize it. So yet another reason to understand behavioral health and trauma in your population and depression and subsequent substance abuse and be able to treat it proactively, because these things definitely have an effect on health outcomes and healthcare utilization. So Dr. Hovis did go already into some of the reasons why in a primary care setting we may not be addressing these issues. One issue is time. Providers just don't ask about these issues because it's not structured in the workflow, and in the 15 minutes that you might have to deal with somebody who has 1 or 2 or 3 chronic diseases, the time might not allow for it, especially if it's not structured already into your workflow. And then if you do address it and identify it, some providers might not feel confident in treating it. As Dr. Hovis mentioned, I think about 30% of care is taking place in primary care settings for mental health disorders, but a huge fraction is going, 57% is going undiagnosed. And then if you do find it, for those individuals that either you might not feel comfortable addressing or that you know that you need to refer or co-manage, there may be a lack of resources for referrals. And finally, if you do refer, we oftentimes practice in organizational silos, so you don't get feedback as to whether the 20% of individuals who actually go, what the outcome was, and you don't know whether those other 80% ever made it to the referral or not. So at MHTG, I'm just going to talk about some of the ways that we are addressing some of these issues. We don't have all the answers, but I wanted to share some of our experiences with you thus far. So the first way that we are addressing care in the urban environment and medically underserved populations is to make care accessible, and I kind of discussed that already. We are a patient-centered medical home, and as such, we practice in a team model. We have multidisciplinary practitioners, addiction medicine, pediatrics, internal medicine, allergy, rheumatology. We also have social workers and psychologists as well. And as I mentioned before, we treat individuals for opioid use disorder. And so we have a special cadre of individuals called peer support specialists that can help individuals. They're individuals who've had a lived experience of substance abuse and are in recovery and have received additional training to help individuals who are going through recovery to be more self-reliant and navigate the healthcare system. And then we also have nurse care managers, and we're bringing in clinical pharmacists now using televideo to do medication therapy management. We're already using televideo within the practice to link the different sites so that an individual who needs to talk with a psychologist or with the licensed clinical social worker around a behavioral health issue can connect internally within our practice to that individual if they're at a different site. We also look at, as I mentioned, we screen specifically for social determinants of health in a comprehensive assessment process that's managed by the social workers. And we're using technology. We have obviously an EMR that is at all sites so that we can communicate as a team and understand what each other are doing. But we also link outside to try to understand how our patients are accessing the healthcare system, and we do that through the Regional Health Information Exchange, or CRISP, in the DC region, that allows us to see when our patients go to the hospital or emergency department or are discharged from those places. And we also use technology to be able, within our EMR, to see how well we're doing, to benchmark and set expectations for how well we're screening our patients, and then be able to follow that and make improvements as we go. One of the initiatives that we're involved with the Medicaid payer in the city is Health Homes 2. It's actually a nationwide demonstration project that some cities have adopted, and we are assigned individuals who have 3 or more chronic conditions who are Medicaid beneficiaries, and we provide care coordination services for them. In doing so, we conduct the comprehensive assessment that I mentioned before, which includes screening for drug and alcohol abuse and misuse, as well as the social determinants of health, and put together a care plan that serves as a map for treatment. The provider is aware of the screening results prior to seeing the patient. And then, as I mentioned before, we use internal quality measures such as, for example, the percent of individuals who are screened for clinical depression and if screened positive who receive follow-up care as a benchmark or a metric to track our progress. And then I think Dr. Hovitz really talked about workflow, so I won't go into that, but I think it's important to mention documentation and the importance of documentation for a couple reasons. Number one, we use our EMR and customize it so that it can provide reminder prompts and guides for documentation to document the PHQ-2 or the CAGE or the PHQ-9. And I'm just showing right here an example of how we document within the care plan the PHQ-9. And it also allows us, by doing that, to be able to easily pull the customized reports to monitor how we're doing in terms of implementing the screens. It also provides an algorithm so that if, depending on what the person's score is, we can, clearly identify this person can be treated within the practice, or if they need to be referred elsewhere outside the practice for psychiatric management. And then I wanted to close with talking about building those co-management relationships. So even though we're multidisciplinary, we don't have all disciplines in-house. So what we've done is proactively develop relationships with community-based organizations as well as other mental health, and other providers to be able to provide the whole person care within a medical neighborhood as opposed to just our medical home. So to do that, we've put into place business associate agreements with psychiatrists and mental health centers, and even treatment facilities for drug and alcohol abuse in the community that are residential or day programs. so that we can easily refer individuals and exchange information about them proactively. Those organizations that have secure messaging, where through their EMR, we're able to send a referral electronically and receive the results of the consult back electronically, so we know that the person has completed care and we can document that effectively in our record. We do rely on the peer navigators for those individuals who may be significantly impaired by drug or alcohol use, to actually hand walk them to appointments, to be able to, with their consent, of course, to be able to increase the probability that they'll actually be able to follow through with the referral. And we're just now introducing the telehealth with psychiatrists, so that when an individual comes in for a primary care visit or for a visit for substance use disorder, we can cut down on that additional barrier to them leaving the office and keeping the appointment or making the appointment by just having the psychiatrist available via televideo to have their first or perhaps even second or third encounter with the patient from our office, which is where they're familiar with and know already how to get to. And then finally, one other very key relationship that we've built is with the 70 Church Consortium in D.C. called the Leadership Council for Healthy Communities, and they actually use a social services electronic referral platform. It's software, and it's HIPAA compliant, and they have also built a referral network of which we're a part, where we can receive referrals for patients that require care, and we also can notify them that we have a patient that requires referral for social services. So that's an additional relationship, co-management relationship that we've developed, again, to ensure that our patients can get their social service needs met outside the auspices of our practice. So I'll stop there, and we'll be happy to take questions at the end.
Thank you so much, Dr. Clark. Really great information. Thank you for sharing today. And at this time, I'm going to turn it over and want to introduce you to Dr. Edwin Boudreau. Dr. Boudreau is a clinical psychologist and a professor at the University of Massachusetts Medical School. In addition, he serves as a subject matter expert, providing tools and education to the Quality Innovation Network, quality improvement organizations that are working on the behavioral health work, part of the QIO program. And Dr. Boudreau is going to lead us through the panel discussion today with our speakers. So Dr. Boudreau, I'll turn it over to you.
Great. Thanks, Kayla. I really appreciate it. And I'd like to thank the speakers for wonderful presentations. And I'm going to open with just a few observations, and then we'll go into some question and answer sessions, because I had a few questions that came up as you guys were talking. So the first observation is that both of you did a great job, and Alan shared his story, which also had some similar themes, that focused on screening as both identification of problems that needed to be treated, so serious issues that actually needed treatment, but also identification of issues for prevention purposes. So in other words, early identification and prevention. And I think that dual role of screening is really important in this context. Patients may vary in the degree of severity of their depression and their alcohol use. So some patients may be above a clinical threshold on depression or alcohol use, but not really have a serious disorder or a disorder that requires treatment, but still shouldn't be ignored. And the earlier we can identify this and work towards preventing escalation, the better. It's obviously clearly better to prevent a disorder before it shows up than to try to treat it once it's there. So I really like that focus on both screening for prevention and for identification of people who need to be treated. I mean, the other common theme that wound throughout both of your approaches was an emphasis on addressing behavioral health in a kind of a matter-of-fact, routine, and respectful way. So this idea that the clinician can influence the acceptability of discussing behavioral health issues through the way they approach the issue, I think it's really, really important. And I know that a big barrier with many clinicians for addressing these issues is this fear of opening Pandora's box. They're a little afraid that they won't know quite what to say to a person who is positive for depression or alcohol, or quite what to do. And I think that emphasis on simply the way you approach the issue is important. And the idea that it's probably more important that you address the problem in whatever way the clinician feels comfortable with than to focus on, specific tools or specific ways of doing it. So it's probably more important to address it at all than it is to say it or address it in a specific way. I really like that idea that it's really kind of how you approach it rather than the specifics of what you say that is probably going to make the biggest impact on the patient. So I just kind of wanted to make those observations about what you guys said, and wanted to see if there's any, before we move on to some specific questions, if you guys have any reactions to those observations.
Well, I like what you said about the prevention, because I think it just lets the patients know that these things are an important part of their health, and it gives us an opportunity just to provide a little bit of education. Like, hey, your body, your liver can only handle this much alcohol a week, or depression can have an impact on your diabetes or this or that, so it gives us a chance to just talk a little bit about it and, let's continue this conversation over time.
Right. Great, thank you. Any other thoughts from the other panelists?
Yeah, I would, this is Melissa Clark. I'd just like to pick up on that theme of being able to address depression and substance use proactively. And I think it's important to also let patients know sometimes that there are certain diseases of which that depression is a manifestation of, such as diabetes or congestive heart failure. That depression is actually one of the symptoms that can be manifested with those diseases, as well as COPD. And so I think that sometimes gives individuals comfort and allows them to be able to address it more proactively when they realize that it could actually be a part of the disease that they're experiencing. And it also gives you an entree to be able to discuss it with them in the context of their overall health.
Thanks, Dr. Clark. Yeah, I really agree with what you just said. It's interesting to be able to engage with in a conversation around the patient, both their medical or physical health and their mental health, and to help them understand how these things work together, and they can feed off of one another, and one disorder can manifest as the other and can influence the management of the disorder. So that seems like a nice segue for having these conversations with some patients, particularly if a patient is presenting with a medical illness that we know has a high comorbidity with mental health, to make sure to pay attention to that with the patient and screen for it. All right. In fact, Dr. Clark, it was interesting you were describing that you work within a medical home, and I know that many practices are not part of a medical home. Much of what you described sounds fantastic. It sounds like you guys have given a lot of thought to treating the whole person and making sure you have resources both in-house and highly connected services that might not be on campus. Can you talk a little bit about how what you presented might need to be adapted for a clinical setting that is not part of a medical home?
Sure. So that was one of the reasons that I really wanted to emphasize towards the end of my presentation, being proactive about developing relationships with other providers in the community. I think Dr. Hovis did a good job of showing those things that can be treated within a primary care practice, and We really didn't cover the reimbursement aspects of this, but for Medicare patients, the expert is reimbursable, as well as 4 visits subsequent to that if it's positive to do counseling. But if you don't have that capability within your practice, developing those relationships with a psychologist or a psychiatrist or a licensed clinical social worker who might even be able to come in 1 day a week and do that, or that you can, again, develop those referral relationships with so that you can make it easy for your patients to sort of navigate that barrier and even maybe have those individuals reach out to your patients if possible.
Yeah, that seems like it would be pretty important. It may require some upfront work, but if you lay the groundwork and have a ready relationship with community-based providers so you can co-manage or refer with them, and even invite them to come on site to spend some time on site, I think that sounds like a pretty practical solution to help make sure that there's an easy answer whenever a patient screens positive and the clinician doesn't feel comfortable with treating it alone. And also I like what you said, too, around developing knowledge about the reimbursement structure. You know, a lot of what drives behavior in the clinic is making sure that reimbursement is coming in to cover all of the effort and time that's spent on this behavior. So if the clinic understands how to bill for the service, then it may make it more practical to actually provide that service.
Absolutely.
Great, thank you. And Dr. Hovis, you had mentioned embedding expert into the existing clinic workflow, and it seems really intriguing in that idea of embedding it in the workflow so it's a natural part of what people do every day. Seems like it has real value, but I can anticipate that there might be some barriers to actually doing that. So what do you think are some common barriers to integrating expert into workflow?
Yeah, I can think of a couple offhand. You know, when I was first presented with the idea of screening as a part of routine care, I thought, man, we already are stretched for time. I don't know about adding something else. But then I slowly saw that really we were taking better care of the patients when we added the screening because we were taking care of the whole patient. And, you know, if your patient is drinking a 6-pack a day, you're never going to get their diabetes under control. So, or if they're deeply depressed, they're never going to take their insulin. So, you know, all of these barriers to care that we have in treating the medical problems have to be addressed anyway. And when we're addressing the whole patient and we're getting to the bottom of these problems, then things are going to go better in the long run, and they're going to be smoother in the long run. So, and two, I think with nursing, that can be a barrier. Nurses have complained, you know, about getting stuck, like you said, opening Pandora's box. You know, sometimes the patients, these are very personal questions, and patients will start talking and maybe start crying, and then the nurses, you know they need to get out of the room and hand the patient over to us. And I think the answer to that is just training. You know, I think all of the staff needs to be on board with this model and be trained in how to, again, make it matter-of-fact and compassionate and a part of the routine care. But, you know, training and restating what the patient's saying in a compassionate way, you know, being trained, saying, you know, I hear this has been a difficult time for you. I'm glad you're talking about it. Let's get Dr. Hovis in here so you guys can discuss this or whatever. I've found that many nurses or medical assistants need some assistance with how to respond to patients when they start talking about these issues. So those are a couple things I can think of.
Yeah, I can totally see the value of having the entire team trained so that you're all on the same page, because I imagine that if that doesn't happen, then things can get fractured and it'll be tense for both the clinicians and the patient. So I really like that emphasis on training and being on the same page. And it seems interesting. There's this time tension. We feel this time pressure to move patients through the clinic and to keep on the schedule. So we might not want to assess behavioral health, but on the other hand, if it's not addressed and it keeps driving patients to come in, and we have to spend time continuing to treat the same medical problems over and over again because the behavioral health isn't realized, then that costs us time in the long run. So it's like either you pay the time now or you pay the time later, right?
Exactly. And this way it's more systematic and direct and to the point. And that's why our screenings are brief. You know, we've chosen the most brief screens we possibly can, but the screenings are very sensitive, you know, and catch a lot. And then if those are positive, the screenings get more detailed and more specific. So.
Right. So keeping it simple so that it does fit into the workflow, and keeping it brief so it doesn't take too much time up front and derail the bed placement process, et cetera. It seems like that would be an important component as well.
Yes.
Something else someone mentioned to me when I was discussing this and how it can be a daunting task to consider integrating SBIRT has pointed out that there are some visits that are more natural to place this in than others. And they pointed out that the annual well visits are a good place because this is the kind of thing that one expects during an annual wellness visit. And it might fit in better with the flow there because there's not usually a specific presenting complaint for an annual wellness visit. And that might be a first step towards integration into routine care is to make sure that this happens at least during the annual wellness visits.
You know, it may be, but what we found that's funny is we actually do them with every single visit. I have a day where I only do procedures, and we still do the screening for depression and substance misuse. And it actually works out really well because that patient's there only for a procedure. So they don't have their 10 other complaints that they usually are bringing in with their annual physical exam. And so while I'm doing the procedure, we can talk about their positive screen, and then, you know, we can make a plan from there. Or if they're in for a same-day sick, it's, you know, our viewpoint is that we want to catch them when they're in distress. So if they're in distress on that same-day sick, like the guy I mentioned who came in, he was basically in withdrawal. That's why he was sick. Or the lady who was in an altercation, you know, she was in distress. She was in a same-day sick appointment. You would think, oh, you don't need to do all these preventive measures then. But we caught him in distress in that moment. Or the patient who's come in for a knee injection, but I find out she's depressed about her weight, which is affecting her knees. And when she's having to get the injection for her knees, she's motivated to talk about her weight and her depression, you know. So we've actually found it really helpful just to do it with every single visit and just make it so routine and matter of fact that it's just a part. And it really does help the patient accept it as part of their visit and as part of their care.
Yeah, that's a really good counterpoint. So it becomes just like vitals that we take at every visit, just like was mentioned in the presentation, it just becomes a little part of the vital signs.
Because those chronic conditions visits and annual physical exams can be very overwhelming with a multitude of problems already. So why not break it up?
Yeah, I totally see that. That makes good sense too. And you know, sometimes people have observed that clinicians might differ in their willingness to do SBIRT for depression versus alcohol. You know, our efforts are really designed to try to improve screening for both, but sometimes for whatever reason it seems to be easier for depression than it is for alcohol. Do you have any insight on why that might be the case?
I think that for depression there's more of a sense from clinicians that, you know, they can treat that with medication, and that there's something definitive that they can do right then and there, or they can refer them to a psychiatrist right then and there. I think with alcohol abuse, people feel that might not be as treatable. And also, again, the finding the resources within the community to do that might also, and doing the referrals might also be perceived as more of a challenge. And those are the reasons that, from what I can tell, that depression screening has a easier uptake or a greater uptake than screening for alcohol.
I totally agree, and I think that's why it's great that you talked about those community relationships. We've got to get better about finding out what's in the community. And we just have to do better with alcohol. You know, everyone's been talking about the opioid crisis, but alcohol and its impact is far more reaching than opioids even. I mean, it is a true crisis, but alcohol has a far bigger impact. And so we've just got to do better in that area.
Yeah, I agree. Thank you for those observations. I'm curious now to ask Alan, as a beneficiary's point of view, we've been talking about making this a routine part of every visit and a routine part of vitals as part of regular care. What's your reaction to that thought as a beneficiary?
I fully agree that the screenings are good for every visit. I think it was good to hear Dr. Hovis say that those are even done with procedures. That is something that normally I as a patient wouldn't think about. But thinking about the two questions and things like that, when I heard earlier how that screening was set up, I feel better about that screening. I understand, its usage, its design better, and how that's set up to help me much better than I did before. So I feel very positive about all of that.
Is there anything that you think would make it easier for the average person to be able to accept a conversation around behavioral health?
Right. The only thing I could think about is if we could talk about, instead of just saying something about depression, well, as a matter of fact, I think the questions that Dr. Hovis was talking about, I forget exactly what those two questions were. Now that we're talking about them today, I don't guess we really asked the question, do you feel depressed? But if we can talk about our symptoms, are you able to take care of your, are you able to manage your affairs well, or, how do you feel, how we feel instead of using a label for it, I do think is more helpful.
Yeah, I hear what you're saying, Alan. So sometimes it's not using the clinical term,
right,
and talking more at a level the patient can understand might help. And you had mentioned yourself that you hadn't identified with being depressed, but you did feel very overwhelmed and kind of under the weight of the world. So that might be a good example of other terms that could be used to kind of probe for how people are doing it and how they're functioning.
Right. That's what I'm saying, and I think that helps me. And I have a wonderful physician. My relationship with him is very good, and I trust him explicitly. But sometimes I guess, despite our best efforts, we may miss something. I had no idea that I would have been depressed, because I always saw depression in the terms of this major depression, bipolar situation that my spouse was in. But yeah, I'm very much glad to hear the dialogue we've got today about that.
Thank you, Alan. So, Kaylee, I think we've had a nice, round table discussion here, and I wonder if you feel it's time for open discussion with the rest of the panel.
Yes, thank you, Dr. Petron. Thank you to the speakers. I agree. This was a great panel discussion, and at this time we can open it up for any questions that we've gotten from participants, either through chat or through the phone line. So I'll cue Tasha, our operator, if you can let participants know how to get into the phone line to ask a question.
Certainly. At this time, if you'd like to ask a question, please press *1 on your telephone keypad. To withdraw your question, press the pound key. Thank you. We'll pause for just a moment to compile the Q&A roster.
Okay, and while she's compiling the Q&A over the phone, I'll turn it over to Racy Nextall to let us know what's the discussion in chat or if there are any questions. Sure, thank you, Kaylee. I know there was some discussion during the panel discussion about the expert, but there's also a question from, a couple questions from Shelley in the chat. How do you integrate expert into primary care, and who does the brief intervention?
Okay. So the screening part of expert we do with the PHQ2 and the NIDA quick screen that I mentioned. And if those are positive, we give the patients we give them a questionnaire actually. We don't have someone ask every question. We give them a PHQ9, we give them the CAGE aid, and then the nurse or the medical assistant lets the provider know that those were positive. They chart it, but they also let the provider know just to make sure the provider doesn't miss it. And then the brief intervention comes from the provider themselves. So that would be the discussion about whatever the issue is, drawing the patient out about it, asking some questions, seeing where their motivation is for intervention. And, brief intervention means just a targeted counseling, basically. And if the patient's open for further intervention, then going from there. If the patient needs medication, further discussion about medication. If the patient needs referral to more specialized treatment, then a discussion about that and a referral to treatment. So the provider basically takes it from there. And if you have a relationship with community partners, then that would be where you would go. Now, some places have psychologists within the building. Here at Cherokee, we actually have developed integrated care where we have psychologists within our building, so we can refer to them at the time of the visit, which is a huge blessing, but we realize that's not the case for most practices. So developing those community relationships would be key.
And I actually really don't have anything to add. We do things the same way. We do have a psychologist actually who is in the office, and so in our largest primary care site, and as I mentioned before, we also have telehealth to be able to link different sites to that psychologist. And we also have a licensed clinical social worker as well who can also do counseling. So in addition to the provider, we also have those resources as well.
We also use telehealth, and we have psychiatry within our system that we can phone for consults at times with questions as sort of a co-management strategy.
Great. Thank you, Dr. Clark. And Shelley, if you have any other follow-up questions with regard to those responses, you can put that in chat or dial into *1 for more specific questions on that topic. And I have several other in chat, but do you want to check the phone lines first, Kaylee? Sure. Tasha, do we have any questions in the queue?
There are no questions at this time, but again, anyone can just press *1 to ask a question.
Okay, thanks. I'll turn it back to you, Lacey. Okay, thanks. So Anna, or maybe Anna, has a question for Dr. Clark. Have you used guidelines to help primary care providers make decisions about who and when patients should be referred to community partners? Over time, have the primary care providers increased the scope of patients they manage themselves?
Yeah, that's a great question. I did allude to that in the talk. So those individuals that score high on the PHQ-9, we do, in addition, the provider does ask questions in terms of their risk for suicidal or homicidal ideations, the desire to hurt themselves or others. And, if they do answer affirmatively to either of those questions, obviously, we would then, that would be considered an emergency situation where we would then refer them to a psychiatrist or actually even to the emergency department, depending if it's clinically indicated. Short of that, we encourage our providers to treat in-house, from a depression point of view, and from a substance use disorder point of view, to also do the brief counseling as well in-house, whether that be the primary care provider, the psychologist, or the social worker. In addition, if the person wants, we also refer to either residential counseling or to support groups such as NA or AA in the community as well. And so those are some of the options that the providers are indicated to do. And as far as changes in the scope of patients that providers manage themselves, yes, we have seen with sort of the positive reinforcement in the workflows, not only have we been increasing the number of individuals that we identify that require additional counseling and care, but providers have been increasingly treating those issues or referring, but increasingly treating right there in the office.
Great, thank you. And Kaylee, I do have a couple other questions in chat. Do you want me to move forward with those? Sure. So from Carla, we have a question as well. Our attempt at working with our primary care providers to increase depression screening on a prior project to snag because we were hearing that physicians did not want to screen because that made them liable to treat the patient for it. Any particular advice you have to give providers to document referrals or counseling so that if the patient does not comply, the liability is not a concern?
Well, first of all, I'd say if you don't want to treat it, then you're ignoring a huge aspect of the patient's health that's affecting everything else. So I would, tend to want to call that malpractice. But I would say that if they're concerned about that, I do understand the concern because they may not feel comfortable, they may not feel well trained, but I do think that we do need to identify the problem. At the least, that's our responsibility in primary care. We may not be experts at diagnosing exactly the type of depression or what exactly is going on or treating exactly. We may need expertise at times, but we should at least screen and identify. And then we should document that we identified and that we talked with the patient about it. We should document that we asked questions, that we ruled out suicidal and homicidal ideation or ruled in and referred appropriately. And I think you are covered if you document that you offered a referral, that you briefly counseled with the patient, and that you offered medication as needed, or if you're not comfortable treating with medication, that you offered referral to psychiatry. I don't think we should shy away from screening just because we're afraid of the liability. We wouldn't stop screening for breast cancer because we're afraid of the liability. I mean, we know that this is a huge part of patients' health and it's deadly. So in the same way, we need to screen for depression. And we do. We just need to document our intervention and what we discussed with the patient and move on. It is up to the patient, and the patient has to take an active role in their care, and we want to encourage them. And I do think that's where motivational interviewing comes into play, assessing the patient's motivation, asking them questions, and not just lecturing them about what they need to do. And it might be helpful for some of these providers. Another tip would be creating some handouts on depression or other common mental health disorders that they maybe could give the patient and review with the patient. These are some things that we recommend. These are some things that might help. And that way they feel comfortable that they've counseled the patient appropriately. But yeah, I think they just document what they've done and move on from there.
Yeah, if I could add to that as well, I think when providers get pushback like that it's really, for the most part, a lack of understanding or feeling that there are the structures in place to support them. So that's one of the reasons that I kind of went through the whole idea of provider accountability and that we're accountable for outcomes with programs like MACRA and NIPS that we're implementing in our practices, that if your practice has taken those steps, that those quality measures that you can look at could be tied to screening for depression or outcomes in diabetes, and then helping the providers understand what the linkage is. And then secondly, either through CME activities or maybe having a psychologist or a primary care practitioner who's comfortable with doing it come in and just do sort of an in-service and walk your providers through sort of what are some of the common clinical scenarios and how to manage them, that would give them the confidence to not really worry about the liability and sort of understand how this fits into the greater picture of what they're doing. And then maybe even understand and tie it to reimbursement and show how for, that the expert exam can be billed for, that the brief counseling sessions can be billed for in the Medicare, and then that also too might help to sort of tie it into their greater workflow and productivity. So I would say don't give up.
This is Dr. Boudreau. I have one other aspect to point out around this fear of liability with both a description of a fear that people have shared with me, but also a personal story. So part of the liability fear often comes from the observation that screening, when it's not integrated into workflow well, and the clinician doesn't understand if the person is a positive screen prior to entering the room, they can end up discharging a patient. The patient leaves the clinic, but there's a positive documented on the chart, and the clinician never knew about it. So that's it's a different version of liability worry than we've been talking about. It's a worry about what if it's a positive and I didn't know about it and therefore couldn't act, and I'm still liable because it's a positive documented on the chart. And that's a legitimate fear, because what I've seen is many times the clinical workflow doesn't support making sure the clinician knows that the patient is positive before they go into the room. And in fact, I just recently visited my own primary care physician for my annual wellness visit, and I was really happy that they gave me this health questionnaire that had a depression screener and an alcohol screener on it. So, of course, this is the kind of work I do. So I was like ready to pat my physician on the back, and I get roomed, and then my piece of paper gets put on the chair. The physician comes in, talks to me, and leaves, and the paper is still on the chair. So the process obviously broke down because here's the screener that was supposed to be used to identify whether I was positive or not, and neither the medical technician nor the primary care provider even looked at it. So I do think that to put into place screening, you have to definitely put into place a communication protocol that's very sound to make sure the clinician knows before they go in to the room that the person's positive, or if it's the clinician's responsibility, and in some clinics it is, then that kind of helps to address this drop issue, this fumble issue, where the information is not communicated properly.
That's good information. Thank you. Haley, I have a couple more questions that I, again, wanted to make sure we're allowing the people on the phone lines, if they've gotten into the queue, to ask their questions.
Yeah, I'll check in one more time. Tasha, do we have anyone in the queue? Yes, we have a few questions. Our first question comes from the line of Debbie Dijak. Your line is open.
Yes, just a question about false positives or false negatives and screening people at a time where they're under a lot of stress, coming in. Maybe they're seeing the practitioner for the first time, and what kind of tracking is done over time.
Mm-hmm. That's a good question, and that definitely happens. I think usually that becomes obvious when you start talking with the patient. Sometimes you find out they've had a recent death in the family and that it's just appropriate grief. Sometimes you find out that they're already being treated for depression, so they struggle with those symptoms chronically, but they're actually stable and they're as good as they've been. Or sometimes you find out they're being treated chronically and they're worse than they've been in the past, so it's important to ask, is this your baseline? Are you better? Are you worse? How are you doing? Have your medicines been changed recently? That kind of thing. So the point of the screen is just to catch them, and know that there's some type of distress, something going on, and then I think when you talk with the patient, you find out, okay, is this something we need to intervene on, or is this just, life stressors? Because, every patient's different, and they answer the questions in different ways, and sometimes it does just turn out to be stress. But I think the more specific questions on the longer screeners tend to be things that, do you enjoy anything, even watching TV and that kind of stuff. And so when you find the people that they're not doing anything, then okay, this is bad. So it gets more specific, and you tend to be able to tease out the clinical depression from the I'm stressed about work or my situational depression.
Our next question. Go ahead.
Go ahead. We have time for one more question.
All right. Our next question comes from the line of Shelley Reese. Your line is open.
Hi, can you hear me?
Yes, we can.
Okay. So my question is, we know that CMS will pay for the expert and visits after with a psychiatrist or psychologist. I'm wondering if those payments by CMS cover the cost of the social worker or the psychologist.
So in our practice, the way we have both Medicaid and Medicare patients in our practice, but the predominance is Medicaid. And so the care coordination program that we paid for, that I described, actually covers the cost of the social worker and the psychiatrist and the psychologist. And we also have a grant to do the telehealth, just in terms of getting off the ground, but we can continue to bill for that. On the Medicare side, then it just becomes supplemental to what we do. I think the reimbursement rate is somewhere between $15 and $30 for private insurance and Medicare for the expert, and then for the counseling, it's something separate. So probably not enough to support necessarily a full-time psychologist and social worker. So we have been able to sort of do this hybrid blend.
So by hybrid, you mean have one or the other, or having them once a week? Or I'm just wondering how to convince people to go to that model when, they might be losing money on it.
Right. So by hybrid blend, I meant because of the number of individuals that we have under the Medicaid care coordination program, we're able to support salaries, and then the Medicare work is just supplemental for the Medicare patients. But if you have a largely Medicare practice, you would have to sort of look at the volume of patients that are screening positive and decide, whether you can support that within the context of your practice.
Okay. One other short question is have any of you thought about using a computer or hotlines, websites in your office, so if they just require a brief intervention, that they might have a little extra thing right there in the office?
We don't have anything like that.
Yeah, neither do we.
Okay, thank you.
All right. Thank you for your questions. And I know there are still a few questions left unanswered in chat, and maybe a few on the phone line. If you are waiting in the queue on the phone line, if you can put your questions into the chat, we'll compile all the unanswered questions and work to get responses to those and put those out along with the slides and the recording on the QIO program website following the call. I want to thank the speakers today. Thank you so much for presenting on our call. I think this was a great discussion and excellent presentation. And as we close out, if the participants would put in any key takeaways that you learned, we'd love to see those in chat. And just as a reminder, please take our post-event assessment at the end of the call. When you close out of the WebEx, you'll be prompted to take that assessment, and then again, the CE credits will follow that assessment. We'd love to hear your feedback on today's event, and also any ideas for additional topics coming up and that you'd like to hear from us on a similar event. So thank you everyone for joining, and we'll end the call.
This concludes today's conference. You may now disconnect.